Hey all, welcome back to the channel. My name is Drew. I'm an accredited exercise physiologist and registered Chinese medicine practitioner for about 20 years clinical experience. And we're learning and sharing and exploring functional anatomy. So functional anatomy is just how the body works in movement particularly. So we essentially have all these different structures or tissues. So we have muscles, ligaments, tendons, and connective tissue. They're the primary ones. And so they're all the kind of the tissues that are involved in stability and movement. And then understanding where they are in the body and their role and how they work really helps us when we're prescribing exercise. If you're a personal trainer and another EP, physio, osteo, we all learn the same stuff. And so when you understand it, it just helps you with your personal knowledge and gives you kind of more confidence and autonomy to kind of really practice and help people and do the things we love to do. So let's have a look at the hip joint today. Hip joint is kind of really simple in terms it's really only got 4 ligaments. I mean, there's a lot more going on clearly, but from the kind of like the bit more of the macro perspective, we have these 3 ligaments here. So we've got this one here. This is the Iliofemoral ligament, which means it goes from the ilium, the pelvis, so the pelvis, to the femur. So that's the Iliofemoral ligament. And then immediately for that, we have the Pubofemoral ligament. So that's the pubic bone here. So attaching onto the pubis, going onto the femur here. It's the Pubofemoral ligament. And then posteriorly, we have the Ischiofemoral ligament, which is this one here. So this is the ischium, and this is the femur, and this is the ischiofemoral ligament. So remember, like the pelvis is made up of the ilium, the ischium, and the pubic bone. Okay, it's essentially all one big bone. All right. But we label the ligaments based on what part of the skeletal structure they're coming from. Now, if you look at the kind of the direction of the fibers of these ligaments, so you've got these superior fibers coming up this way from the iliofemoral ligament, and then you've got these more oblique fibers coming through there. So this kind of ligament is going to really kind of stabilize the anterior part of the hip. So particularly if the leg has been pulled back that way or more posteriorly into extension. And when you add that with the pubofemoral ligament, extension and abduction. So when you bring your leg behind you, that's going to tension that ligament. So that's going to provide stability through the anterior portion of the hip joint. Whereas on the posterior portion, you have the ischio-femoral ligament, and then also the kind of the superior fibers of the iliofemoral ligament as well, providing stability for adduction and hip flexion as well. So you kind of have this 360-degree kind of stabilization. So the role of these ligaments is essentially to keep the head of the humerus here. So if we isolate that, the head of the femur here, nice and snug into the acetabulum here. If we isolate that into this big socket here, this is the acetabulum. So this rim around here, it's the acetabular rim. And there's another ligament there called the labrum. So we might put that in a minute, which kind of like provides a little more depth and stability to the hip joint, the hip socket itself. So these ligaments are really designed to keep the hip nicely in position whilst it's moving. Like all ligaments, we don't want them flexible, we don't want them stretched. We want them nice and strong. They have a little bit of pliability in them, but they're not designed to be flexible. You want them pliable. You don't want them stiff where they don't move, but you want them to have that kind of fixed range, because you don't want the ligaments to be stretched out. Otherwise, you get ligament instability. So commonly in chronic shoulder dislocations or knee dislocations, the ligaments are quite lax because they've been overstretched or they've been torn. And so they lose their stability role. So all movements are always a trade-off between strength, flexibility, and stability. And we want to have a nice combination of all 3 where we can. The 4th ligament is the joint capsule itself, which is on here on the left. So it's a continuous capsule, goes all the way around, and it really traces the rim of the acetabular rim here. So that whole, if we isolate it again, so it's really wrapping around all this part of the bone through here. And then it's going to wrap around the head of the femur as well. So if you look here, it's going to wrap around the entire head of the femur. So this is your head of the femur, and that's the neck of the femur, and that's the greater trochanter, and that's the lesser trochanter. So the 4 key landmarks of the femur. So head of the femur, neck of femur, greater trochanter, lesser trochanter. So greater trochanter, you've got muscle attachments of piriformis, glute medius, glute minimus. They all attach pretty much up on here. And here, the lesser trochanter is where your iliopsoas, your iliacus and your psoas muscle attaches here on the front. So that will be all encapsulated by your joint capsule itself. So it's really strong connective tissue that wraps around front to back. And one of the roles of connective tissue, it will secrete nutrients into the joint space, synovial fluid as well. So we do require movement to help secrete those nutrients in that synovial fluid to lubricate and oil the joint. So your mobility type exercises like gentle stretching, gentle yoga, or just mobility exercises themselves are really designed to kind of lubricate the joint and promote that kind of smooth movement in the joint. So often your warm-ups when you're exercising are targeting the joints and getting the joints lubricated and warmed up particularly. And that takes a couple of minutes to kind of happen. And then also you're activating the muscular system. So you're kind of like getting the nervous system ready to respond to whatever it is you're doing. So an exercise style like Qigong or Tai Chi is very much orientated around not so much muscular contractions. You have to contract your muscles to create the movement, but you're using the least amount of muscular traction to create the movement, and you're really kind of getting a lot of joint lubrication because as you're moving through your forms, you're relaxing as much as possible. The joints and the connective tissue do take a lot more of the loading. So over a long period of practice with Tai Chi and Qigong, your connective tissue gets quite well developed, gets quite strong. And it's one of the kind of the magic parts of Tai Chi and Qigong, because the energetic system, the Qi or the energy or the streaming potential moves through the connective tissue, not so much through the muscles. So the more you can relax during your movement practice, the more you'll get an energy flow or a streaming potential through the connective tissue, which is pretty cool. So that's our 4 main ligaments of the hip. If we put in the hip labrum, let's see, labrum. Let's put it on the left. So click it there. Isolate. So here we have a labrum, which is like a ring of cartilage that sits on the outside rim of the femur. Let's try fate others. No. Through there. No. So often you'll get people do labral tears in the hip joint. And so a labral tear is where you get a little bit of a nick in this connective tissue, which sits along the rim of the pelvis. So that labrum is going to sit along the rim of the acetabular here. Okay, a little bit of space through there. So you'll often get labral tears or labral nicks, where you just a little bit of a cut in that little bit of the connective tissue front, and they can kind of like catch. And so often people get like a clicking and then a kind of catching feel in the hip. and it's typically the labrum that's getting caught. It's kind of like a little paper tear, and then you get a little flap, and then depending where the flap of the tissue is, it might sit back down smooth and then it'll heal itself. Or if it keeps, for whatever reason, sitting up and getting kind of caught, it can kind of create issues, and they can be really, really painful and quite debilitating on people's hip joints. And often that might require a bit of a surgical intervention just to kind of clean it up. So it's not like a major life-threatening problem. It's just one of those really annoying kind of injuries where they just kind of prevent you from doing a lot of the things you like to enjoy doing. Often it's usually the hip flexion on the front where you get the little labral tear. So that's a quick little overview of the key ligaments of the hip. So we've got the labrum going around the acetabular rim, and then we've got the anterior hip joint ligament, which is the iliofemoral ligament going from the ilium down to the femur. Then we've got the posterior ligament, which is the ischio-femoral ligament going from the ischium to the femur. And then we've got the anterior medial one, which is the pubofemoral ligament through here. And they all have a kind of like a twisting component to it. So they keep the femur nicely snug and stable in the pelvis, in the acetabulum. And then we have the joint capsule, which that sits on top of all these ligaments. So these ones are kind of encased in this big ligament here. And that kind of keeps everything in its nice structure, its nice stability. So when you have a hip replacement, depending on what they do, they're going to have to cut into this hip capsule here. And depending what they're doing, what type of hip replacement they do, they might have to kind of like cut these ligaments and then reattach them as well. So typically the hip replacement is getting much, much better, depending on which procedure they use, but just the nature of the procedure, it's going to create a little bit of instability. And that's the trade-off because the joint itself is worn out and the pain of the osteoarthritis is pretty significant. So you replace the joint with an artificial joint. And to do that, they need to actually pop out the femur out of the acetabulum. To do that, they might need to kind of like cut away some of this tissue here and then surgically reattach it. So, and that process can create a little bit of instability. So when you do have a hip replacement, if you do, you tend to have some restrictions on movement. So you don't want to like take your legs too far out of the abduction and then internal external rotation, because that can like twist the head of the femur, and if you get the right angle can pop it out because you've got this little space here as well. So that's a little weakness in there. And I have worked with a few clients who accidentally dislocate the hip post hip replacement, and it's not a good time, so don't do that. But the key thing with your hip replacement, if you're getting one, is you must strengthen all the hip stabilizer muscles around. So for example, medius in, must strengthen glute medius. Okay. This one here is your primary hip stabilizer. When it contracts, it pulls the femur up this way, which kind of pulls the head of the femur snugly into the socket. So if this muscle here is weak, it can create a lot of instability in your hip. So when I'm working with clients who've had either they're doing prehabs or getting ready for a hip replacement surgery, we do a lot of work in getting this muscle strong, or post rehab, we do a lot of work in getting it. Either way, you have to get it working. And the one that's often forgotten, other muscles would have forgotten, will be your psoas. Psoas is your primary hip flexor muscle. So that's the stabilizer to the front. So if you don't get this muscle strong, you lack anterior stabilization. Okay. And then your adductors. Let's have a look. Adductor, let's go magnus, because it sounds cool. Adductor magnus on the left. Okay, so if you want a good hip joint a nice stable hip joint, you want glute medius, psoas, and adductor. There are 7 adductors. Let's just say adductor magnus. So adductor magnus is when it contracts, it's going to pull the femur inward, so medially, so adduction, and then upwards. So this kind of superior line, which will again stabilize the femur in the socket. Then you've got psoas, which is going to again pull up and pull the femur into the socket. And then glute medius, which is also pulling up. So the 3 muscles will pull the femur into the socket and keep it in this nice snug position. Then that allows the move muscles of the leg, so the glute max, the hamstring, and the quadriceps to do with the rec fem, to do the primary hip movement. So before you work the quads and the glute max, you want to make sure these muscles are kind of active and working. That's really the magic sauce to pretty much all hip rehabilitation. If you can get these 3 muscles working really well together, and then retrain pelvic mechanics, because if the pelvis is in the wrong spot, these muscles tend not to work very well. So, for example, if this muscle here, if you're fully anterior tilted, okay, that tends to tighten up this muscle here, creates a short and tight position, and then locks your pelvis in the anterior tilt, so you can't posterior tilt as effectively. And posterior tilting is where glute medius really comes into its own. So if you go too far in one direction, you weaken the other muscle groups. And it's always about creating the balance of movement stability and flexibility within the system. So when we get around to actually looking at the rehabilitation exercise for different conditions, because we're setting up all the foundation of the anatomy, so you've got a good understanding of the anatomy. When we start looking at exercise prescription and how we prescribe exercise, it all really makes a lot of sense, because you've got to understand the role of the adductor, the role of the psoas, the role of the glute med, and then how they work individually and then as a team together to stabilize the hip. So I'm looking forward to teaching you guys that stuff. So if you have any questions, please do me a favor, drop me a comment below, like and share, because apparently YouTube likes the like and the share in the comments. And we will keep working on our ligaments. And in the next one, we're going to be looking at is the sacroiliac joint, which is this big joint here, the ligaments of the sacroiliac joint. So until then, keep training, keep practicing, stay curious, stay humble, and we'll see you in the next video.